Well, hello, everyone. It's an honor to be with you today. I have the privilege and pleasure to speak to you today about my approach to caring for individuals with advanced cancer. I'm defining advanced cancer as cancer that we do not believe can be cured given current science. I've been a doctor caring for people with advanced cancer for more than a decade. Specifically, I am a medical oncologist, or a doctor who provides chemotherapy to individuals with sarcoma, a rare cancer of the bones and soft tissues. I'm also board certified in hospice and palliative medicine. Briefly, hospice is a specialized form of medicine that focuses on the comfort and quality of life of individuals who are thought to be nearing the end of their lives. Hospice focuses on providing support to the patient as well as their loved ones, even after the patient dies. In contrast, palliative medicine is for any individual with serious illness and can be used at any time, even when cure is possible. Palliative medicine clinicians manage symptoms, help patients and families clarify their goals, and support optimal communication and planning. I don't have any financial conflicts. However, I did want to mention that I am Vital Talk faculty, and this approach to communication, particularly with advanced cancer, is embedded within my approach to care, and so you will see overlap. So what's different about this presentation? I want to provide fair warning that this talk may be very different than what you're used to hearing at scientific conferences. As I speak about my approach, I won't be talking about cutting-edge treatments or ongoing clinical trials. Instead, I'm going to be focusing on what I think of as age-old truths that I think do apply to clinicians and individuals with serious illness, as well as caregivers and really anyone who is trying to live fully with the remaining time that they have in this lifetime. Some of what I say may sound obvious or simple. It could be painful or hopefully inspiring. But I'm convinced that the most meaningful things in life are often those things that we are already very much aware of, and yet still find difficult to embrace or enact in our lives in a consistent day-to-day way. During this talk, you're also going to hear music and see images. I hope that this allows you to immerse yourself in the content and really see if it applies to you. I invite you to take a few deep breaths now in the spirit of meditation, to clear your mind and to reach out to those around you and to simply be. Finally, I want to acknowledge that I have not had cancer or faced a serious life-threatening illness. I have only my perspective. However, together we have years and years of collective wisdom, and I hope you will feel comfortable sharing yours during the question and answer session. And with that, let's begin.
Said I was in my early 40s with a lot of life before me, when a moment came that stopped me on a dime. I spent most of the next days looking at the x-rays, talking about the options and talking about sweet time. I asked him when it sank in that this might really be the real end. How's it hit you when you get that kind of news? Man, what'd you do? And he said, I went skydiving, I went Rocky Mountain climbing, I went 2.7 seconds on a bull named Blue Manchu, and I looked deeper and I spoke sweeter and I gave said someday I hope you get the chance to live like you were dying. He said I was fine.
Death is inevitable. I believe you must accept this on a deep and visceral level to be a clinician who cares for those with advanced cancer. Holding this belief in a daily way is a skill that you must build in order to cope with the repetitive loss. As clinicians, we do not have the power to stop death. We may briefly stall it, but it's never truly overcome. There is no cure. And accepting this truth is crucial because when death is recognized as inevitable, you are not a failure if your patient dies. You have not done anything wrong. There is nothing to forgive. And as a result, you can stop defending yourself and set aside any fears and your own ego. And the same is true of caregivers. You are not a failure if your loved one dies. Death doesn't happen because you decided to take a bath or have a massage, see friends, or go for a long walk. And as a patient, you are not responsible. It isn't what you ate or drank or inhaled or the exercise that you didn't do. When you accept that death is inevitable and therefore not a failure, you are able to participate in that age-old mystery. And when you accept death as inevitable as a clinician, you can reframe the cancer experience not as a tragedy, but as an opportunity for transformational positive change. Cancer can be our clarifying tool in our lives and in the lives of our patients and their families. As the goal shifts from avoiding death to prioritizing the most meaningful and joyful things in a person's life. And I want to assure you, this is in no way giving up. Instead, I think of this as waking up. And as a person with cancer or their loved one, this doesn't mean that you stop fighting for each precious moment, but it does mean that you consider what you're fighting for and how you will define success in this new worldview. Finally, when you accept death as inevitable, it becomes clear that life is not inevitable. Life takes hard work. It's difficult to live each day truly alive, to live each day like you are dying. Our lives are really a reflection of where we choose to put our attention and our intentions. And I'm trying to support this effort in each cancer patient, in each loved one, in myself and in my colleagues.
Trouble me, disturb me with all your cares and your worries. Trouble on the days when you feel spent. Why let your shoulders bend underneath this burden when my back is sturdy and strong? Trouble
do I mean by the phrase "we are in relationship"? It's not a typo. I did not mean that we are in a relationship. This might also be true. But what I mean is that we are always in relationship to others. Who we are and what we become is in that space in between. As a result, I try hard not to say "I understand" when talking with patients and their loved ones. The reality is that I do not understand. I do not have cancer. I also do not know you. I have not lived your life. And I don't know who you were before this diagnosis. I am certain, though, that cancer is not the sum total of who you are or who you were. Research from Karen Steinhauser and others teaches us that there are at least 6 domains that are important to achieving a meaningful end of life, and that these domains were defined by patients, caregivers, and doctors alike. They include good pain and symptom management, clear decision making, preparation for death for both patients and caregivers, completion, which typically includes issues of faith and spirituality, but also life review, resolving conflict, saying goodbye, and spending time. Contributing to others is another domain, which is really legacy, but not in the limited financial sense that we often talk about wills, but rather providing time, knowledge, and support to others. And the final domain is affirmation of the whole person. This, I think, is one of the most important. The most effective thing I can do to achieve these 6 domains is to build my understanding by talking with you and your loved ones. My first goal is to understand, what do you know? Or what do you think you know? And then, what do you want to know? Ensuring the first, what do you know, is incredibly important to ensuring that I provide you with new information and that I correct any misunderstandings. This helps us build a strong foundation to our mutual understanding. And for most people, knowledge is power. But for some, knowledge can be debilitating. It can send some patients and caregivers swirling or ruminating to dark places that are not helpful or productive. And most people know this about themselves if you ask them. So for those people, it can be better just to focus on what is necessary right now in order to participate in care and to take good care of themselves. Next, I want to know what matters most. What are your goals? This is critically important to shared decision making. Patients and loved ones can't possibly take everything into account or know how to weigh the pros and cons or how to evaluate each intervention or which questions to ask. But hopefully I can give you more of the right information at the right time as I know you better. And this is how we ensure that we use all of our time and energy, those precious resources, to their greatest effect. When I know what matters most, in addition to what you're worried about or afraid of, and the things that you want to avoid, I can help anticipate what might be coming and give recommendations that can help you have a better experience.
Give mercy to someone in need. Give mercy. Don't you see? Life will break our hearts again and again. We'll keep being broken till we remain open. Can't you see? I have broken wide open. Let yourself be broken wide open. I have broken open.
As a clinician, I'm frequently meditating on the idea that vulnerability and strength are not opposites. Vulnerability and strength are not opposites. I'm attempting to make room and time for the vulnerability and strength of myself, my colleagues, my patients and families. But what does that mean exactly? Well, to me, it means, at least in part, that I cannot expect people to be in relationship with me without trust. And often trust means honesty. I have to admit the uncertainty of the larger situation and the limits of both science and my knowledge. And I cannot shy away from difficult topics or questions, including how one dies and when that might occur. However, I also strive to be aware that vulnerability can be either experienced as a positive or a negative, particularly by patients and families. I must commit myself to navigating power dynamics with humility. And it's also important to remember there will be emotion, both my own and the emotions of others. I am constantly learning and growing in my role, and each patient and family is unique and special to me. And that means that I am vulnerable. In my experience, there may be many human emotions. However, within cancer treatment, most expressions of emotion boil down to fear or love. So when I'm feeling emotional or confused, or when I'm witnessing strong emotions in others, I often ask myself, what's driving this? And then I cultivate compassion for the loving or fearful response. that underlies the emotions that I'm observing. I also try to be very sensitive to the person who appears calm, focused, logical, or measured. Exerting control is a normal human reaction to uncertainty. But control and calm are not necessarily equivalent to strength or acceptance. Individuals who are trying to exert control rarely have time to address their grief, disappointment, regret, or fear. And in turn, they also rarely have the opportunity to experience fully hope, joy, laughter, and play. So if, as a patient or a caregiver or clinician, you are interacting with someone who is striving to be in control or seems too calm, I suggest that you be wary of that. It is the calm water at the surface that belies the roaring river below. And finally, I am a human being. I let go of the myth of perfection. There are no perfect doctors or patients or caregivers. My goals now are really toward authenticity, meaning love and sustainability. And the last of this list is often the most important and the most underappreciated for everyone, patients, caregivers, and clinicians. Sustainability means I cannot let my fire consume me. When I let my fire consume me, that is burnout, right? And that's saying about, putting on my oxygen mask first is a truism. We have to take care of ourselves first. And limits may be necessary to prevent your fire consuming you. This is how you define your balance between being and doing. But it's not just important to have limits for ourselves. We also have to enforce limits on others in the midst of advanced cancer. For example, I frequently see patients and caregivers struggle with when and how often to have friends or family visit. Or for patients, how much time to allow your caregiver to spend with you each day when you and your caregiver may be yearning for a little time apart and then the joy of reconnecting. As a caregiver, you may have to create limits on how many updates you provide and to whom. As I said in the beginning, life is not inevitable. We have to decide for ourselves how we will spend each day. And we must learn to be less apologetic or unapologetic for creating our own lives. For this last section, I don't have any words, just an intention.
I I see trees of green, red roses too. I see them bloom for me and you. And I think to myself, what a wonderful world. I see skies of blue and clouds of white, the bright blessed day, the dark sacred night. And I think to myself, what a wonderful world. The colors of the rainbow, so pretty in the sky, are also on the faces of people going by. I see friends shaking hands, saying, how do you do? They're really saying, I love you. I hear babies cry. I watch them grow. They'll learn much more than I never knew. And I think to myself, what a wonderful world. Yes, I think to myself, what a wonderful world. Oh, yeah.
Thank you so much for this opportunity to share. Take good care.
Wow. Dr. Loggers, that was amazing. Thank you so much for taking on that incredibly difficult topic and doing it with such profundity and perceptiveness. I'd love both of you, Meg and Dr. Ann Elizabeth, to show yourselves. I'd like to introduce Meg Gaines and Dr. Loggers. If you have questions, please put them in the Q&A. Hi, Meg.
Hi, Joni.
Thank you for being here.
Lovely to be here. What a great way to start. Amazing.
Hi, Elizabeth. Hi, Dr. Loggers. So, Meg, do you want to start us off?
Yeah, I was so touched, Dr. Loggers, by all of that. And I was really struck by a couple of things. One is that the link you made from the very beginning, that your talk was for anyone trying to live fully with their remaining days, and linking, I think, clinicians and patients and caregivers and everyone involved in the situation as basically having the same challenge and the same opportunity, right, as you describe it. So I would really want to underscore the opportunity for people to think about that, for clinicians as well as patients to think about how your approach would be different to the situation if you saw everyone in the room as someone who was just trying to live fully their remaining days, and we thought about it that way. And I think your notion about, to me, you were talking about that at the high end, living fully your remaining days. And then at the kind of other side of it is the sort of basics. How do I stay sustainable, right? And this is, of course, true for both patients and clinicians. And you talk a lot about clinicians setting physical limits, but early on in the talk, you talk about clinicians getting their heads in the right space so that every death doesn't feel like failure, so that every fear that gets expressed, you don't have to assuage. Every time patients come to terms with the sort of ultimate nature of this diagnosis, you don't actually have to fix it, because that's not necessarily how it's going to go or in your toolkit. I mean, it's so hard, right? Because you have tools to fight this, and we all want to fight it, but you can't get lost in the notion that that's the only way, that we have to talk like that until we finally turn around and say, okay, we don't have anything more. And as patients, I think that's a very stunning moment. We're like, wait, what? You've been a warrior in my corner, and now you're telling me that I need to go see the palliative care lady? Like, at 2 Brute, how can you let me down like this? So it does have to be much more, I think, integrated in a sense, right? And it is about integrating one's own mortality. So I loved it. I thought it was great. Terrific.
Thank you.
Do we have questions? Or should I keep babbling? Because I can continue to babble forever, Joni, you know that.
I just think you summed it up so well, what I was intending. So thank you, Meg. That was really very much appreciated.
Oh, it was really, really fantastic. I do think it's hard for patients, when you get the diagnosis and you're processing mortality, it's really hard for patients not to feel like the walls are closing in. I mean, this is why I really think all chemotherapy treatment centers should have big windows to some beautiful natural something or other, because I think it's very easy to feel like you almost can't breathe and that the walls are coming in, and the fear gets very intense. But stepping outside the front door or looking outside to a beautiful kind of natural environment, even if you're in a city, if you can see the sky, or Northwestern has this incredible view of the lake from their chemo unit. And I think just the ability to see the vastness of nature just opens up that feeling of suffocation. And so I always tell patients the 2 things to do. One is go outside. If you can go outside in any way, shape, or form, or look outside. And if you really can't, then put on music, for the same reason as your talk kind of illustrates, right? That music can really transport us from the reality we're stuck in to a different kind of place when nothing else is possible. So
I have a question. So, Meg alluded to the moment of sort of the pendulum swing from we had options, and now we don't have options. But there's a moment that comes earlier than that I wanted to speak to. And that's the moment when you first diagnose a cancer. And as a doctor, that we can get time, but we aren't going to get cure, at least not with current science. And I think each of us paints that in a different way, because you're at the beginning of a journey with somebody. You're not at that pendulum swing into hospice. You're actually at the beginning of a moment when you're starting down, the relationship that could go on for years. And I'm sort of wondering, from your perspective, Elizabeth, how do you approach that conversation, or what would you say, to us as we enter into that moment with our patients?
Yeah. So I do think, as clinicians, we always try to approach each patient and family as an individual, and we try to get a sense of what's valuable and important to them and how they want to have that conversation. I try to be respectful if people don't want to have that conversation. And yet I think it's honestly the most important conversation that we have, distinguishing when we are still fighting for cure and when things have changed and we've moved into that space where cure isn't currently possible. I think that's really important. And I try to be very clear and upfront about that, because I think, as Meg was saying, there's
you have to know that in order to shift your thinking towards how do I spend each of these days most meaningfully. Um, we can't have that thought at the front of our thinking every moment of every day, but it has to be guiding how we make our choices. And so, you know, if I'm working with someone and I don't think they have a sense of the timeline, I think it's important to have that conversation. You know, how much information do you want? What sense of a timeline it would be important? What and I tell people, you know, what's interesting about this in my experience working with people is that the moment in time that this is most important actually moves, right? So if that time frame is, you know, 3 months, it's different than 6 months, it's different than 1 year, it's different than 3 years, right? And where you are in that really does affect decision making, I think. But there's a gray area where it doesn't affect it as much as you might imagine in terms of decision making. And that, I think, is that's the critical time, because you as an individual and as a clinician and as a caregiver, you really have lots of choices then, right? If you've got 5 years, that's very different than 6 months. And so finding where that gray area is for each patient and family, I think, is incredibly helpful, because it allows them to prioritize in ways that if you're unaware, you just can't, because you didn't know prioritize it. And then when you realize that, all of a sudden there can be this moment where you realize, oh, I don't have time to do the things that I would have thought were important in that time. And that's what I'm always trying to avoid, is that retrospective regret. You know, I tell people we're going to make choices and we never want to look back. We just always want to look forward and say, those were the best decisions I could make in that moment with the best information I had at that time.
I have a follow-up. That's really helpful. A follow-up question, if I'm not cutting you off, Meg. And that's that I've had the experience where my patient has not wanted to have as much information and has wanted to me to pipe the hope side of things, and the less sort of, you know, data-driven, you know, statistical side of things.
Yeah.
And has also not necessarily wanted to protect her family from the reality of what she's going through, and therefore maybe not involve them as much in all of the harder conversations. And then, but the family needs something different, and the partners may need something different. And I've actually been pulled aside by partners after the passing of some patients saying, you know, I wish you had spoken to me differently. I wish you had told me more concretely what I needed to know. And so there was a conflict for me between what my patient needed and what her family needed. And I'm wondering what we would say to that.
Yeah, absolutely. I would say that's absolutely a reality. And I have two general responses to that. The first is simply, if I feel that that's happening in the room, I try to be very clear about it. And I'll just say, you know, my sense is that each of you needs something different from me in terms of communication. And I wonder if we could each meet separately. Would that be okay? Would you be comfortable with me talking with your partner separately? Because I want to make sure I'm caring for both of you to the best extent possible. Now, if it comes to brass tacks, I'm the patient's doctor, and I'm going to do what the patient wants. But I've never been in a situation where if I gave those two options, that people didn't say, yeah, please have a private conversation, give them what they need, because they love each other. And so they're going to try to do, you know, the best. And then I think the other thing that I just want to throw out there is that when somebody tells me that they really want me to not discuss specifics, I ask them if they'll engage with me in a hypothetical conversation. I ask them, you know, if we're thinking about the movie of your life and we're at the closing scenes, what does that look like? If you'll tell me what that looks like, then I'll absolutely protect you from those conversations. But I'll be making sure that I get, you know, that I do the best that I can to get you to that last movie scene. And so if I can, it's hard. It's hard, and it's incredibly hard for each of us to talk about these things. But most of us have an idea of what we would want if we could choose. And as a clinician, I can help you get there because I know what choices now will lead to different outcomes later, just from experience. And so that's what I'm trying to anticipate.
I remember calling my oncologist, which I had his cell phone number, but I never ever called him. But I called him one morning at about, I don't know, I'd been up since about 4, squirrel caging, as I like to call it. And I called him, and he was in the shower. So his wife answered and said, "I'll have him call you." So he called me back, and he said, "How you doing?" I said, "Good." You might know him, actually. It was Skip Shink. Maybe you know him, maybe you don't. But anyway, he said, "I'm good. How are you?" "Good, fine." I said, "Listen, I need to tell you something, and then I need to ask you a question. And I'm a lawyer, so I'm not going to ask you a question you can't answer, but I need to, So here's what I need you to know. I don't want the last 2 weeks of my life. I don't want to be on a rented hospital bed in a room, with my children barely recognizing them and going from this many pounds to that many pounds. I don't want it. There isn't anybody I have to say sorry to anymore. There isn't anybody I have to, anymore. We're all good. The relationships are all good. So let me ask you the question now. Here's the question. Question is, knowing that, do you feel comfortable continuing to be my physician? In other words, would you help me make that happen? And he said, first of all, the answer to the question is yes, I feel comfortable continuing being your physician. But second of all, we're nowhere near that yet. And I said, I understand. I just need to know right now. So apropos of what does it look like at the end? I had a very clear sense of what I wanted it and didn't want it to look like at the end.
We just have one more minute. Dr. Lagers, do you have anything else you'd like to close us out with, or?
Somebody in the Q&A said, it's like being an octogenarian, that everything that Dr. Lagers said is applicable to being an octogenarian. And I think that's exactly what you said, right? That anyone trying to live fully their remaining days, we are all in that boat. So whether you're a cancer survivor or a cancer patient or a clinician or anybody else, right? We're all in that same boat, trying to live fully remaining days, with some of us more aware of the hammers hanging over our heads than others.
Well, and I think I'm also trying to promote a sense that we are, and you said it really well, Meg, in the beginning, that that as clinicians, I may not be the person with the illness, but I am constantly aware of this, because every day, every room, every recommendation, I am acutely aware of it. And in order to be a clinician in that situation, I have to be in touch with my own humanity, my own mortality. And I have to be able to convey that to you so that we are never on different ends of a rope pulling against each other, but we are actually in the same boat. And I'm facing the same things. So I want us all to have much more of a partnership in the way that we are together with this, because your tragedy is my tragedy, actually. And I know sometimes it doesn't feel that way to patients and families, but it's in there with me all the time. And I have to find ways of coping with that, and to still be the best doctor, the best advocate, the best partner for each family and patient. And I think that's part of the calling that you've heard so much about today. And I know I see that in Dr. Hope and Dr. Hardesty all the time. And that's why I love being here and being part of this particular conference. So.
Yeah, and it doesn't feel like that, it doesn't feel like it's our tragedy if clinicians haven't done the work to face their own mortality, to let go of the notion of death as something other than inevitable, right? As a failure. It doesn't, when the ego's in the room, it doesn't feel like it's a mutual tragedy, right? Or a mutual challenge. And so that is the point. I thought that point was tremendous. And patients also have to come clear with the notion that death is inevitable. And, that it's not failure if it happens here. It's not your doctor's failure.
So thank you so much to both of you. Thank you so much. You really, when I asked you to do this talk, I knew that you would just speak from your heart. And I really, really, really thank you for doing that. So we have to move on to the next talk, but thank you very much. And I'll talk to you soon, no doubt.